Good afternoon, everybody, and welcome. My name is Julie Crystal, and I'm the moderator for this afternoon's session. One of my favorite topics, and I hope yours, neuroblastoma and related tumors, presented by Dr. Emily Greengard from the University of Minnesota. A few announcements before we start. Don't forget to use the chat box and the Q&A feature to ask questions. If you see questions that you want answered, you can also click to vote the question to raise it in the priority list. After the video portion of the lecture, there will be a live Q&A time in which I'll go through those questions and present them to Dr. Greengard, who will be able to give us some answers. If you're having any issues viewing the session, try refreshing your screen or visit the support tab at the top of the screen. Now we're going to turn it over to Dr. Greengard.
Hi, my name is Emily Greengard. I'm from the University of Minnesota, and I'd like to thank ASPHO for inviting me here today to talk to you guys about neuroblastoma and related tumors. So this talk will follow the topical structure suggested by the American Board of Pediatrics. We'll cover basic science and pathophysiology and risk assessment of these diseases, diagnosis, management, and treatment of these diseases. So starting with the basic science and pathophysiology of neuroblastic tumors, neuroblastic tumors are embryonal malignancies that originate from the neural crest tissue of the sympathetic nervous system. They encompass a spectrum of tumors that are characterized by varying levels of neuronal differentiation, with ganglioneuroma representing the most differentiated, neuroblastoma being more intermediate, and neuroblastoma being the least differentiated. And ganglioneuroblastoma's behavior are really characterized by whether they're intermixed, which behave favorably, or nodular, which will behave in the nature of the neuroblastic nodule, how that's comprised. Neuroblastic tumors have a very heterogeneous clinical course. They range from this interesting phenomenon of spontaneous progression to being highly aggressive, widely metastatic disease with a fatal outcome. The pathologic features of neuroblastic tumors, when you look at them under the microscope, they appear as small, round, blue cell tumors. They have a Homer right rosette patterns. So the tumor cells surround a neuropil to look like this rosette. And as I talked about before, there's ganglioneuroma, ganglioneuroblastoma, and neuroblastoma. These each have varying degrees of not only neuronal maturation, but also mitosis and karyorrhexis, and varying degrees of Schwannian stroma intermixed with the tumor cells. On this slide here, you can see different depictions of what a neuroblastoma might look like under the microscope. So the top left picture is a neuroblastoma that's differentiating and has a low MKI, a more favorable tumor. On the top right is a poorly differentiated neuroblastoma, many small round blue cells, but if you look really closely, and it's hard to see, it has a low MKI and not very many mitoses within the cells. On the bottom right is a picture of an undifferentiated neuroblastoma with high MKI. So the cells are very mitotically active. This would be unfavorable histology neuroblastoma. And then on the bottom left is a depiction of the classic Homer right rosette pattern with the neuroblastoma cells surrounding a neuropil. We have really learned over the past few decades that there are several significant molecular drivers of disease in neuroblastoma. And interestingly, what we think is that aberrant telomere maintenance really leads to an aggressive phenotype in neuroblastoma. We certainly know that a certain percentage of neuroblastomas are driven by MYC and have MYC-N amplification or overexpression. We also know that in older kids with neuroblastoma, inactivating mutations in ATRX, a gene involved in chromatin remodeling, leads to activated alternative lengthening of telomeres, the ALT pathway, which is a very aggressive phenotype. And this occurs, like I said, in older patients and exclusive of MYC-N amplification. Finally, another mechanism for aberrant telomere maintenance is activating rearrangements in TERT. This occurs exclusive of both MYC-N and ATRX mutations and is present in about 13% of neuroblastic tumors. We also know that there are two broad patterns of chromosomal changes in neuroblastoma. There are whole chromosomal gains, where you do not have any structural changes, and this can result in a hyperdiploid DNA content, which is associated with an excellent clinical outcome. However, in the presence of segmental chromosomal aberrations or a diploid DNA content in a tumor, an more aggressive disease course can be expected, and this is associated with an inferior outcome. It's hypothesized that these segmental chromosomal aberrations result in altered telomere lengthening, which is responsible for the more aggressive phenotype. The most common segmental chromosomal aberrations that we see in neuroblastoma are at chromosome 1p36 and at chromosome 11q23. There are additional somatic mutations in neuroblastoma as well. We know that ALK aberrations occur with amplification detected in about 4% of high-risk neuroblastoma tumors, and activating ALK mutations, I should say mutations, not aberrations, occur in about 14 to 15% of high-risk neuroblastoma. We also know that there are chromosome 17q gains, although the specific gene involved is not known, as well as deletions and point mutations in ARID1A and 1B, which are chromatin remodeling proteins. Finally, in a small percentage of tumors, you can see p53 mutations, mutations in PTPN11 associated with Noonan syndrome, and then mutations in genes involved in the RAS and MAP kinase signaling pathway. These mutations are often enriched at relapse. Moving on to the epidemiology and risk assessment, we know that neuroblastic tumors account for 8 to 10% of all pediatric cancers. They're the most common extracranial neoplasm in childhood and the most common solid tumor, even when you include brain tumors, in children less than 1 year of age. The median age at diagnosis is 19 months, and there's a slight male predominance. There is, however, no geographic variation in the incidence, but we do know that African Americans and Native Americans are more likely to have poor prognostic features associated with their disease and poor outcomes. On the left, you'll see a depiction from the SEER database that shows on the x-axis age and years of diagnosis, on the y-axis average annual rate per million. You can see that the chance of being diagnosed with a neuroblastic tumor decreases dramatically once you're over 5 years of age. And you can also see the slight increase in predominance in males, the blue line, versus females, the red line. We do know that there are a handful of genetic predisposition syndromes that can result in neuroblastoma. Germline mutations in the anaplastic lymphoma kinase gene, or ALK, account for 1 to 2% of neuroblastoma diagnoses and account for what we call familial neuroblastoma. So this should be suspected in somebody who has a strong family history of neuroblastic tumors, or a child that presents with bilateral adrenal tumors or multifocal disease. FOX2B germline mutations result in a neurocrystopathy syndrome, in which you see central hypoventilation, Hirschsprung's disease, as well as neuroblastoma. And then several other syndromes, such as neurofibromatosis, Beckwith-Wiedemann, Lee-Fraumeni, and Noonan syndrome, can result in a child developing neuroblastoma or a neuroblastic tumor. Also, germline deletions at the 3.6 or 11q14 locus can increase the risk of neuroblastoma as well. The prognostic features of neuroblastoma include many. One big one is age, and in North America, being greater than 18 months of age, a diagnosis is a poor prognosis than being younger at diagnosis. In addition, the stage of the disease, the pathology or histology of the disease, as well as the presence or absence of unfavorable genetic aberrations such as McGinn amplification, the other aberrations I mentioned before, really help to determine the prognosis of the disease. This is the old International Neuroblastoma Staging System, which is really based on the extent of surgical resection of the tumor for patients that present with local regional disease. We now use the International Neuroblastoma Risk Group Staging System, the INRG staging system, in order to take out the role of surgery, the extent of surgical resection and determining the stage, and really base the staging on pre-surgical imaging. And the other reason for the development of this was to make sure we have a consensus across the world in how we stage neuroblastoma. So the staging for local regional tumors is really defined on whether there's the presence or absence of image-defined risk factors. So an L1 tumor is a localized tumor not involving vital structures, so no image-defined risk factors, and confined to one body compartment. Whereas an L2 tumor is a local regional tumor with the presence of one or more image-defined risk factors. And of course, stage M disease is distant metastatic disease, except for MS, which MS is the old stage 4S disease, metastatic disease in children less than 18 months, with disease confined to the skin, liver, and or bone marrow. There's a list of image-defined risk factors that help determine L1 or L2 status. Now, the International Neuroblastoma Pathology Classification is used to determine whether a tumor is classified as favorable or unfavorable histology. This takes into account the tumor morphologic features prior to therapy, which is key. It has to be prior to therapy, looking at the amount of Schwannian stroma, the degree of neuroblastic maturation, and the mitosis karyorrhexis index of the neuroblastic cells. This is all taken within the context of a patient's age, with being less than 18 months at diagnosis more favorable than being older than 18 months. Because of that, it's challenging to be classified, have a tumor classified as being favorable in a child that's greater than 5 years of age. As you get older, you really must have increasing differentiation of a tumor with a low MKI in order to be classified as having a favorable histology tumor. The classification is an independent prognostic variable for outcome. We know that poor prognosis is associated with less neuronal differentiation and high MKI. When we look at risk stratification by prognostic features, we take all of these prognostic features into account and classify kids as having low, intermediate, or high risk disease. And you can see in this graph on the right, when you look at survival by risk classification, children with low and intermediate risk disease in the dashed blue line, that's intermediate risk disease, the dotted black line, that's low risk disease, do quite well, whereas children with high risk disease in that red line do very poorly. And because of that, neuroblastoma accounts for 10% of childhood cancer mortality. This is the International Neuroblastoma Risk Group Pretreatment Classification Schema, which I sort of talked through before, so I'm not going to go through this in detail. There is a much more updated, extensive version of this that is being published as we speak, I believe. So you can keep your eye out for that. Moving on to the diagnosis of neuroblastoma. The clinical presentation of neuroblastoma is really quite variable and depends on the location of the primary tumor and whether there is metastatic disease associated with that as well. So symptoms associated with the primary site of disease or nodal metastatic disease include the presence of a palpable neck mass, abdominal distension, a Horner syndrome in the setting of a cervical or high thoracic tumor, genital urinary symptoms, neurologic abnormalities such as even paralysis if somebody presents with spinal cord compression, and hypertension. Symptoms associated with metastatic disease include classic constitutional symptoms, fever, ill appearance, malaise, irritability, weight loss, anorexia. Kids with bone or bone marrow metastases often present with pain. It can be ill-defined. And kids with metastases to the orbit can present with proptosis or even the classic raccoon eyes, bruising around the eyes. Kids can present with respiratory distress due to either abdominal competition from a large abdominal mass or a large liver infiltrated with tumor, or due to thoracic disease. In addition, kids can present with effusions, lymphatic, chylous effusions, malignant infusions, and then even skin nodules. There are a couple paraneoplastic syndromes that we know are associated with neuroblastic tumors. The first one is opsoclonus myoclonus ataxia syndrome. This occurs in approximately 4% of neuroblastoma diagnoses. Occurs also in patients that you can't find a neuroblastoma in, and it involves a constellation of myoclonic jerking, random eye movements, the dancing eyes of opsoclonus, with or without cerebellar ataxia. These are typically associated with favorable neuroblastoma features. These kids typically have a good outcome in terms of their neuroblastoma, but can have long-term neurologic and cognitive deficits from the OMAS. These include psychomotor retardation, learning challenges, behavioral issues, speech issues. So that can be really a very challenging syndrome. Kerner-Morrison syndrome is the classic tumor that secretes vasointestinal peptide that causes intractable secretory diarrhea, which resolves once the tumor is resected. So there are several imaging modalities that can be used for staging neuroblastoma. We want to evaluate both the local regional involvement as well as the metastatic burden. So anatomic imaging to evaluate the local regional involvement is typically CT or MRI scan. You for sure want an MRI scan if you have a paraspinal mass, if you're evaluating for spinal cord compression. In order to evaluate the extent of metastatic disease, the most common mechanism would be through the use of a radio-labeled meta-iodobenzoguanidine scan, or I-123 MIBG scan. We know that about 90% of neuroblastoma tumors have the norepinephrine transporter, which means that they will, their tumors will take up the MIBG. And this can be very useful in determining the extent of disease. For those patients whose tumors are not MIBG avid, FDG PET can be used. FDG PET can also be used in other circumstances as well. But certainly MIBG would be the most common. Bone scans are quite outdated at this point in time, given that MIBGs are more sensitive and specific, and FDG PETs are also more sensitive. They can still be done at diagnosis, but they're really not used in the evaluation of response any longer. And then one thing I wanted to mention was that GA dotatate PET scans are a newer modality that are not widely used yet and should not be on your boards, but just something to know about as a up and coming way to image neuroblastoma. So here are some pictures of these imaging modalities. On the left is the CT scan of an adrenal primary, as you can see here. In the middle is a planar imaging from a MIBG scan, this patient that has a likely adrenal primary and then multiple sites of bony metastatic disease. This over here on the right is a PET scan. As you can see, the brain is hot on the PET, as are the other sites of disease. But because the brain is hot or black on this image, hot on the PET, it's really hard to image these cranial metastases that you can see very well on the MIBG scan. Something to keep in mind. Laboratory studies and pathology studies definitely aid in both the diagnosis and risk stratification of neuroblastoma. Certainly, tumor biopsy is used for histologic grading as well as molecular and cytogenetic analysis of the disease. Bone marrow aspirates and biopsies are needed for staging and also can be useful in the setting in which it's too difficult to biopsy a primary tumor, it wouldn't be safe for the patient, or in the incidents in which no primary tumor can be identified, which certainly does happen. Urine catecholamines, the metabolites, HbA, VMA, can also be useful when diagnosing a neuroblastoma. They're secreted by 90% of neuroblastoma tumors. And in the setting in which, again, if you can't find or biopsy a primary, the diagnosis of neuroblastoma can be made if you have the elevation of HbA, VMA, and bone marrow pathology that's consistent with neuroblastoma. There are other non-specific markers that we talk about in neuroblastoma. NSE is a stain that we can do on biopsies of the tumor or marrow, and then elevated ferritin and LDH are often seen at diagnosis, and if elevated, can portend a poor prognosis. A little bit about neuroblastoma in the bone marrow. When you look at a bone marrow under the microscope, you'll see small round blue cells. They're often, but not always, larger than the lymphocytes. And you can see this kind of depicted nicely in these two pictures where you have these large neuroblastoma cells. Typically, they'll appear in cohesive clumps of 5 or more cells and take on this polygonal shape. On the left, this is sort of the classic Homer right rosette formation. And then on the right is this, what we call paving stone pattern that they can form. That being said, you can also have cells that are sort of just found individually throughout the marrow without forming clusters or nest, and this is described as a leukemic pattern. And if you do immunohistochemistry on them, on these cells, they should stain for S100, CD56, PGP 9.5, NSE, and synaptophysin. So our typical neuroblastic tumor stains. Moving on to the management and treatment. I'll go through this by risk stratification since the treatments are so dramatically different depending on what the risk classification is. So for low risk neuroblastoma, we know that the outcome is excellent. And given that, the mainstay of therapy is surgery alone, or alternatively, even observation without a biopsy. So for patients undergoing surgery, the goal, if you are going to have your patient undergo surgery, is to resect the tumor without damaging any normal organs, vital structures, really without causing any morbidity for the patient. Delayed surgery can definitely be considered, even delayed biopsy for patients with symptomatic MS disease. It should be considered because these patients are often critically ill and can decompensate if undergoing even a biopsy. And I cannot stress enough that complete resection is not mandatory. Observation alone without even a biopsy was studied in a COG pilot study in infants with small L1 adrenal tumors. It was found to be very safe. Most kids were able to avoid surgery. There are ongoing trials now to assess for observation of additional small L1 non-adrenal primary tumors, as well as larger L1 adrenal primary tumors. And then also ongoing studies looking at observation only after biopsying a L2 tumor that's found to have all favorable histology and genomics. Chemotherapy for low risk disease is really reserved for acute life or organ threatening symptoms, or in the setting of recurrence after surgery or observation for low risk disease. And radiation also is really only used in the setting of acute life or organ threatening symptoms. Intermediate risk neuroblastoma also carries a really good prognosis with event-free survival greater than 85%, overall survival greater than 90%. And treatment of intermediate risk neuroblastoma is really guided with the goal to achieve a greater than 50% reduction in the primary tumor size, and with resolution of the metastatic disease if the patient has metastatic disease. And this can be done via surgery alone, potentially, or chemotherapy alone, or a combination of surgery and chemotherapy. So with surgery, certainly you want an upfront biopsy for genetic and histologic data to help you understand whether this disease is truly intermediate risk or not. And then you can do a delayed resection to achieve a greater than 50% reduction in the primary tumor size if you need to do a resection at all. Again, complete resection is not mandatory. The chemotherapy is response-directed chemotherapy, and this was defined initially in the COG trial ANBL 0531. So patients received 2 to 8 cycles based on the response of vincristine, carboplatin, Cytoxan, and doxorubicin, again, with the goal of reducing the primary tumor by a volume of greater than or equal to 50% and having resolution of the metastatic disease. That being said, there are some situations in which patients are going to get a longer duration of therapy regardless of the response, if their tumor has an unfavorable histology or if there are unfavorable genomic features like segmental chromosomal aberrations or a diploid tumor, or in younger kids with stage M disease. So these patients receive at least 4 and sometimes up to 8 cycles of chemotherapy. In intermediate risk disease, radiation is reserved for the acute life and organ threatening symptoms, just like in low risk disease. Now, high risk neuroblastoma therapy is multimodal, very intense therapy, given the prognosis for high risk neuroblastoma remains quite poor, particularly in comparison to intermediate risk disease. So high-risk neuroblastoma therapy is done in phases. The first phase of therapy is induction, which involves 5 cycles of multi-agent chemotherapy. Stem cell collection occurs after the second cycle of chemotherapy, and surgery occurs typically in between cycles 4 or 5 of chemotherapy, sometimes after cycle 5 of chemotherapy, and in rare circumstances, not at all. If a primary tumor can't be found, if it's unresectable, or if it responds significantly to chemotherapy. After patients complete induction, they move on to consolidation. This is tandem high-dose myeloablative chemotherapy followed by autologous stem cell rescue or transplant, whatever terminology you like to use there, and then external beam radiotherapy. After completion of consolidation, patients move on to post-consolidation therapy, which is the combination of isotretinoin, which is a biologic response modifier, as well as anti-GD2 immunotherapy. I just want to talk through the role of these different components a little bit. The role of biologic response modifiers, such as isotretinoin and immunotherapy, were defined in a couple of different children's oncology group or children's cancer group trials. So the first one was CCG 3891. That was a children's cancer group trial that randomized patients to receive isotretinoin or not as post-consolidation therapy after they completed all of their chemotherapy. This trial showed that patients who were randomized to receive retinoic acid did have an improved event-free survival compared to not receiving it, and thus this was adopted to move forward as part of standard of care therapy. Then in ANBL 0032, the pivotal study looking at anti-GD2 immunotherapy, patients were randomized to receive anti-GD2 immunotherapy with dinutuximab, IL-2, and GM-CSF with cisretinoic acid or cisretinoic acid alone after they completed their consolidation therapy. So this Kaplan-Meier curve shows the event-free survival on the y-axis, the time in years from enrollment on the x-axis. And you can see the red line depicts the patients randomized to receive isotretinoin plus anti-GD2 therapy. The blue line is retinoic acid alone. And patients that received the combination had event-free survival of 66% compared to 46% for patients who received retinoic acid alone. This is a 2-year event-free survival. So because of this study, anti-GD2 and immunotherapy along with retinoic acid has been moved forward as the standard of care for high-risk neuroblastoma in North America. One thing I do want to mention is that since this time, our European colleagues have really studied the role of IL-2 in this setting, and they have found that IL-2 does not improve outcomes, but definitely increases toxicity. And because of that, we no longer include IL-2 in the regimen, and it's anti-GD2 immunotherapy along with GM-CSF and isotretinoin. Now, to move on to the role of myeloablative chemotherapy and high-risk neuroblastoma, this was first defined also in the CCG 3891 study. So the study had 2 randomizations, the isotretinoin randomization, but prior to that, they randomized patients to, after they completed their induction chemotherapy, to go into continuation chemotherapy versus 1 round of myeloablative chemotherapy and stem cell transplant. Again, looking at event-free survival, 3-year event-free survival from the time of randomization. And I just want to be clear that the 33% is for patients that got the myeloablative chemotherapy versus 22% 3-year EFS for patients who got chemotherapy, just continuation chemotherapy. So this was a statistically significant improvement for patients who got myeloablative chemotherapy. And again, this was moved forward as a standard of care in North America. This was revisited again in AMBL 0532. So after the results of CCG 3891 came out, several investigators were thinking about, well, perhaps if 1 transplant is better than none, maybe 2 is better than 1. So that's what AMBL 0532 investigated and randomized patients to a single round of myeloablative chemo and autologous stem cell transplant versus tandem, so 2 rounds. And again, the event-free survival for the patients who had the more aggressive therapy, tandem transplant, was improved as compared to patients who received only 1 transplant. And this was most evident in patients who also went on to receive immunotherapy. So the 3-year EFS from the start of immunotherapy for kids who got tandem transplant was 73% versus 54% for kids who got a single transplant. Again, statistically significant value or change. Now, a little bit on the role of surgery in the treatment of neuroblastoma. I talked about this before a bit, but to reiterate, in lower intermediate risk disease, the goal is to achieve reduction of the primary tumor by 50%, particularly in intermediate risk disease. This can be done by chemotherapy alone or surgery alone or both. And in high risk disease, the goal really is to achieve complete resection of the primary tumor, but not at the cost of damaging critical organs or structures. So you want to preserve these critical organs or structures, vessels, what have you, even if that means leaving a little bit of tumor behind, even in high-risk disease. And we also don't really think about margins and trying to achieve negative margins in neuroblastoma like we do in most of our other solid tumors, where that is really quite important. Moving on to the role of radiation in the treatment of neuroblastoma. As I said before, for lower intermediate risk disease, it's reserved for the emergent management of life and organ threatening symptoms. For high risk disease, standard of care involves radiation to the primary tumor of about 21 gray. The volume is based on the pre-surgical tumor volume after induction chemotherapy, as well as kind of the margin around that. AMBL 0532 really looked to better understand the role of giving a boost. So an additional dose if there is gross residual tumor after surgery. But this was found to not increase the local control success rate and thus is not being moved forward as standard of care. So no boost being moved forward as standard of care. Radiation can be used to metastatic soft tissue and bone sites that persist at the end of induction. And sometimes we consider what's left at the end of consolidation as opposed to the end of induction. It really depends on how much metastatic burden the patient continues to have. And the timing of radiotherapy is following tandem transplant. This table I'm not going to go through because it just sort of summarizes everything that we talked about, and you can reference that yourself. I want to move on to understanding a little bit about the International Neuroblastoma Response Criteria. This was first published in 1993. It has since been revised. This is the original, so I'm not going to go through it in detail. The revised INRC that we use now was published back in 2017. It's based on 3 distinct components, and we put them all together to determine the overall response. So the distinct components are the response of the primary tumor, the response at the metastatic soft tissue and bone sites, and then bone marrow response. Also important is that in the revised criteria, as opposed to the original criteria, HbA/VMA levels are not incorporated into the response assessment. They are not found to be reliable. And functional imaging, PET or MIBG, is incorporated to assess the response in bone and bone marrow disease. In addition, there is a semi-quantification of bone marrow disease to assess response. The old very good partial response and mixed response are no longer used, but there's an added definition of a minor response that captures the response in metastatic sites in the setting of having stable disease at the primary tumor. So these are the new categories for overall response in the revised criteria. So there's a complete response, partial response, minor response, stable disease, progressive disease. You guys can sort of study this independently. And then the division of primary tumor response, metastatic soft tissue and bone response, and then bone marrow response. If you put them all together, you get your overall response. I do want to just highlight that the bone marrow response is really defined quite nicely. So you can really determine specifically what that response is in the bone marrow. And this is part of the revised criteria. Unfortunately, there are a lot of complications and late effects of treatment for neuroblastoma, particularly high-risk neuroblastoma. Certainly, we know there can be surgical complications. We know that radiation carries some acute, but many long-term side effects, such as organ dysfunction that are really dependent on where the radiation is delivered to. It can result in altered musculoskeletal growth, infertility, secondary malignancies. Chemotherapy, we know, comes with a host of late effects, acute and late effects. Many kids with high-risk neuroblastoma will have hearing loss. Some can have cardiac toxicity. Many will have infertility, and some might develop secondary malignancies, particularly secondary leukemias. We know that the biologic therapy can decrease bone density, can result in growth issues. And we know that immunotherapy comes with a whole host of acute adverse toxic effects. But the late effects are really yet to be determined, given that it's still a relatively new modality in high-risk neuroblastoma. So now I wanted to move on to those related tumors, which are really pheochromocytomas and paragangliomas. These are rare in pediatrics, but we still need to know about them because we see them from time to time. So we'll talk a little bit about the basic science and pathophysiology. So these tumors are neuroendocrine tumors that arise from the chromaffin cells of either the sympathetic tissue in the adrenal or extra-adrenal abdominal locations. These are sympathetic pheochromocytomas and paragangliomas. They result in secretion of norepinephrine and epinephrine, and most of them arise in the adrenal medulla, but not all. Parasympathetic pheochromocytomas, or really paragangliomas, I should call them. They rarely secrete catecholamines. They occur in the thorax, head, or neck. 10% of pheochromocytomas are malignant, 25% of paragangliomas are malignant. There are 3 different molecular subtypes of these. There's a pseudohypoxia subtype that involves mutations that overexpress VEGF and result in impaired DNA methylation. There's a subtype that involves the Wnt signaling pathway, and then a subtype that involves kinase signaling pathways such as PI3 kinase, AKT, RAS, RAF, ERK, and mTOR pathways. Now, these molecular subtypes result in biochemical phenotypes. So the pseudohypoxia-related tumors result in a noradrenergic phenotype in which patients have elevated norepinephrine, norepinephrine levels. These are often due to germline von Hippel-Lindau mutations, succinate dehydrogenase types A, B, C, or D mutations, fumarate hydratase, and several other mutations. The adrenergic phenotype is caused by the kinase signaling related tumors. They're typically adrenal tumors and often are related to germline mutations in RET, NF1, or TMEM127. The dopaminergic phenotype is related to germline mutations, particularly in the succinate dehydrogenase B and D genes. And these tumors secrete dopamine, hence the name, with or without mild increase in norepinephrine, and these occur in the head and the neck. So epidemiology and risk assessment, this is a very rare tumor, particularly in pediatrics. In most of them in pediatrics, about 80% are associated with a genetic predisposition syndrome. And we know there are at least 20 known susceptibility genes. Genetic testing, because of this, genetic testing really should be performed in all pediatric patients that present with a pheochromocytoma or paraganglioma. Independent risk factors for metastatic disease include the presence of a SDHB germline mutation, extra-adrenal locations, a large size of a primary tumor, younger age at initial diagnosis, and elevated 3-methoxytyramine levels. So the diagnosis is based on both documentation of excessive catecholamine excretion for biochemical testing, and then also localization of the tumor by CT or MRI. The measurements of fractionated metanephrines are done in urine or plasma or both. And then in order to evaluate for metastatic disease, really probably the preferred method these days is the GA dotatate PET, which is a somatostatin analog and is quite sensitive in detecting these tumors, or an FDG PET alternatively. These tumors like to metastasize to the lungs, the liver, the bones, and the lymph nodes. MIBG SPECT CT can be considered if you're considering MIBG therapy for metastatic disease, and I'll say a little bit more about that. The clinical findings are really related to catecholamine release. So the classic symptoms of the triad of headache, diaphoresis, and tachycardia in the setting of hypertension. Hypertension is by far the most common sign, and it can be sustained or paroxysmal. And headaches occur in the large majority of patients as well. This kind of postural hypotension can also occur, as well as certainly anxiety, panic attacks related to this excessive excretion of catecholamines. The management and treatment for localized disease is surgical resection, and you definitely want your endocrinologist and your surgeons highly involved in the planning of this. These patients are going to need alpha blockade followed by beta blockade prior to their surgery. The treatment for metastatic disease is very challenging. It carries metastatic disease or unresectable disease carries an incredibly poor prognosis, and there are really no known curative therapies. So chemotherapy can be tried. It's not very effective. Molecular targeted therapies with sunitinib or everolimus can also be attempted. And then I want to talk a little bit about the role of radioisotope therapy for these diseases, as well as for neuroblastoma. So iodine-131 MIBG therapy has been used since the 1980s for the treatment of relapsed and refractory neuroblastomas and pheochromocytoma paragangliomas. There have been several trials, mostly through the NAT consortium, the Neuroblastoma Consortium and Children's Oncology Group, that have demonstrated both the safety and efficacy of MIBG therapy for kids with relapsed and refractory diseases. There's an ongoing phase 3 randomized trial as we speak, AMBL 1531, looking at MIBG therapy up front for kids with high risk neuroblastoma. In addition to that study, the current focus is also how we combine MIBG therapy with novel agents for relapsed and refractory disease, with the most recent studies looking at vorinostat, looking at combining it with anti-GD2 immunotherapy. So we'll see how those things play out. And then finally, lutetium-177 dotatate is a really interesting, relatively new radioisotope therapy. It's oral, which is incredibly nice. It does not require an inpatient admission. It's a radio-labeled somatostatin analog, and this treatment actually can be repeated like every 8 weeks. This was FDA approved in 2018 for the treatment of somatostatin receptor positive neuroendocrine tumors. So really, the paragangliomas and pheochromocytomas would fall under this. So this is definitely something that should be considered for patients with paragangliomas and pheochromocytomas with metastatic or unresectable disease. And I think as we move along, we'll see more and more about this therapeutic option for children with neuroblastoma, but that should not be on your boards now. So I think that's all I have. I thank you guys for listening. Good luck on your boards. I know you all will do fantastic, and I am more than happy to take any questions that you might have at this time. Thank you.
Okay, great. Thanks so much, Dr. Greengard. We're going to go through some of the questions, and I want to bring up a couple of things that have been recurring questions. So I want to go back to the very beginning. There was a lot of questions about what staging system people should work on knowing for the boards, the INRG or the INSS. Dr. Greengard, do you want to talk about that a little bit?
Yeah, I do. So there were a lot of questions regarding that, and my response was that I think you should focus on the INRG rather than the INSS. I feel certainly 100% confident about that in your everyday clinical practice. I hesitate a touch because I don't know for sure what the boards is going to ask you guys. And so I think it'd be good to be familiar with what the old staging systems are, and just making sure you understand kind of how the old one translates to the new one, I guess.
Yeah, I think that's a great point. And I think they could, as everybody knows, neither me nor Dr. Greengard knows what the questions on the boards are, right? We're just trying to guide you guys as best we can. And certainly a question could mention a stage from the INSS, give you an example of a patient who has 4S or something like that. And you would want to be familiar with what that means. So I think that's good advice. Let me just go back through another couple of things that we wanted to talk about. Okay, I think this is an important point. What point responses are evaluated for high-risk patients and how they might change treatment? For example, a patient with high-risk therapy who has progression during induction and other time points when you might evaluate disease.
Yeah, so I think, and I hope I answered this question correctly. So Julie, certainly you chime in as well, but the first time point for assessing responses, like complete the whole overall response is after induction, end induction. And in that setting, what we would all love is to see that a patient has a complete response, but we know that that is not the case in a lot of situations. And so a progressive disease at that point in time, you really would want to change your gears and not, march along with standard high risk therapy. A lot of people would change pathways if a patient has stable disease at that point in time and think about something like chemoimmunotherapy. Some people would even do that in the setting of a partial response, but the verdict is kind of up in the air about that. And I think, once you sort of decide which pathway you're going to go after induction, if you're marching along that pathway of going on to transplant, for the most part, you continued on that pathway throughout therapy unless you have progressive disease. But there's so many nuances to this and so many different ways it can go. I don't think that this will be like a focus of the boards, unless you truly have progressive disease. It's hard for me to imagine they would ask about that.
Yes, agree. And a couple questions on this. If you can explain when is radiation given to high-risk patients, at what point during therapy, and how do you decide which sites to radiate?
Yep. So all patients with high-risk disease should get radiation therapy to their primary site as long as they have a primary tumor. We know sometimes in rare circumstances a primary tumor cannot be found and then you don't have a primary site to radiate. But all patients, regardless of whether you have a complete response to chemo or a complete resection, all patients will get radiation to their primary site after sorry, I got distracted by the questions. I won't look at those. After recovery from tandem transplant. And then the site of the metastatic disease sites really depends on your response. So if you have multiple sites of metastatic disease and they all go away, you do not get radiation. They all go away at the end of induction, you do not get radiation to your sites of metastatic disease. But if you have at least 5 sites of metastatic disease remaining going into transplant, then following transplant, before you go on to post-consolidation, you would consider radiation to the sites of remaining metastatic disease. And, I don't know if they'll ask about that on the boards or not. I think most important is that all patients with high-risk disease get radiation to their primary site. But I suppose it's possible.
I hope not.
All right.
And there were a few questions, and this is difficult to give a one answer to, but there are some questions about what gets observed and what kind of follow-up. And I think maybe talking just about the L1 tumors, what gets followed versus treated, and what kind of follow-up is, what should be universally followed is maybe something that can be said.
Yeah. I mean, I think what can be universally followed is that a small, like less than 3 centimeter L1 tumor can be observed without a biopsy. Now, whether families are comfortable with that is a whole different story, but I think for the purpose of the boards, a small adrenal tumor can be observed. I would say anything outside of the adrenal gland, it's not proven that it's safe to observe without a biopsy. So I would not say for the purpose of the boards, that would be a safe answer. I think just to tie into that, there's a lot of questions about MICN amplification and risk and the INRG table. I think that I would not memorize that INRG table. It's not boards. It's not a set in stone, so it shouldn't be asked on the boards. And I think that when it is ultimately published, a L1 fully resected tumor is going to be low risk, but I would not really worry about that right now. I think what's most important to know is if you're over 18 months and you have, stage 4 disease, it doesn't matter if you're MICN amplified or not, you're high risk. If you're, or stage M disease, sorry, if you're less than 18 months, there's a lot of other factors involved, except for if you're MICN amplified, then you have, high risk disease, but there's a whole host of factors involved. So I would really focus on, kind of what factors really make you high risk in the setting of stage 4 disease, I think, or intermediate risk.
Right. And there is some debate these days and changes coming about some of these certain groups of patients. And I think they will not get into that because it's not fair, because experts are still debating that today. So I think it'll be very clear cut, and age is important. No 18 months higher, lower, and no NMIC and no stages. And that will, they're not going to give you one of these groups that people are still not sure about. So it should be clearer than that, I hope.
Like the 12 to 18 month olds with unfavorable histology.
Right. Right.
Yes.
That's debated for hours at COG every year. They're not going to ask you about that on the boards. Yeah. Okay, we have time for one more question, and I'm going to just pull it out of the group here because I think there may be some confusion about this. It comes up for our fellows as well because of the use of MIBG for imaging and for therapy. Can you clarify that a little bit?
Yeah, absolutely. So MIBG itself, meta-iodobenzoguanidine, is not radiation. It's just a substance that is taken up by, the neuroblastoma cells. For imaging diagnostic purposes, it's radio labeled with either iodine 131 or 123, most commonly 123, at really low doses. So that's where we use it, for imaging for diagnostic purposes. For therapeutic purposes, it's labeled with iodine 131, and then you give really high doses so that it does act as like internal radiation therapy. But it's not, MIBG itself is not what's radioactive. It's radio labeling it with iodine that makes it radioactive. I hope that makes sense.
Yes.
And it's like an internal radiotherapy injected in the vein. And then lutetium 177 is FDA approved for all ages, I believe, for the neuroendocrine tumors. It's not for neuroblastoma. And that is also a radioactive therapy, radioactive isotope. So lutetium is the radioactive substance, and it's lutetium dotatate, which is the somatostatin analog. So a similar concept, just different isotopes and agents that are connected.
Great. Okay. That is all the time we have. Thanks to everyone for attending the session, and thanks so much to Dr. Greengard. The chat and the Q&A are going to close. There is a recording of this session, and it will be available on your page later today. Please watch out for further details where there will be virtual office hours in late February and March for another chance to talk with Dr. Greengard. The next session for you guys is Wilms tumors and other renal tumors. Exciting. It will begin at 3:15 Central Time, 4:15 6:15 for us here on the East Coast. So go out of this room and then you should join that session after about a 15-minute break. I hope everybody enjoys the rest of the course. Good luck to everybody.
Thanks, Julie.
Bye-bye. Thanks, Emily. Have a great